Okay, next talk is about airway fires. It's mostly about surgical fires. I put laser in there because that's the thing that's focused most on. But there are more fires caused by the bovie than laser because we use bovie 10 times more than we use the laser. I couldn't find anybody videotaping themselves while they were having a surgical fire. I guess that's kind of a liability issue. But this is the video that some surgeons, anesthesiologists thought it would be useful. I think it's useful. It's a bad example. You can always be a bad example to teach because the airway fires never happen like this. We never keep the laser pointed on that area with 100% oxygen running through the tube. So it's a lot subtler. You don't see these flames, but the injuries are real. There are about 550 to 650 surgical fires every year. They're underreported. The reporting isn't voluntary. So by, I don't know, conservative estimate, I guess it's at least 3-4 times that high. It causes serious injury, disfigurement, and death. And most of them happen in the head and neck area. So if you're asking which procedures cause the highest risk of surgical fires, look no further than these good-looking young men and women from the ENT department, particularly this guy here, much younger. These guys, if you're not careful, their procedures are gonna be the highest risk procedures for airway fires. You have to keep your eyes on these guys, especially this one. Because we use all of the supplemental oxygen, flammable materials, ignition sources around the head and neck where the oxygen is there. We share our airway with you. You have to keep your eyes on it. Otherwise, we'll be singing this song. And you don't want to hear us sing that. There was an AAOHNS, American Academy of Otolaryngology member survey, and about 25% of the respondents said they had experienced a fire in the operating room. So the real incidence is much more than 600 in the survey. Near miss events are 3 to 4 times as many. Majority of the fires on the patient happen in the head and neck and upper chest. Majority of the airway of the fires in the patient happen in the airway, and the incidence was comparable in several procedures, whether it was endoscopic or open surgery, and 85% of them happened during the presence of oxygen. 95% head and neck, 50% were cited for substandard care. I mean, if you have a badly burned patient in a courtroom, there is no way you can win anything. 90% of them were paid off, resulted with a payment to the plaintiff. Median is $70,000 up to $320,000. Here are a few basics. This is the fun part. The rest is boring. Is oxygen flammable? Plus. Is oxygen lighter than air? Kevin? Kevin's not here. Is nitrous oxide flammable? Is oxygen absorbed by fabric? Well, the answers do not lie in these charts. This is, it just looks nice. It has nothing to do with the subject. And this is the seating plan for an entertainment establishment in London, but it said oxygen, so. Oxygen isn't flammable. Oxygen is heavier than air, so it accumulates under the drapes and it's absorbed into the drapes. Is nitric oxide flammable? No, it's not. But when you apply heat, nitric oxide turns into oxygen, which is also not flammable. But in the presence of a substrate, heated nitric oxide acts the same way as an oxygen source. We need fuel for the fire. And the fuel is us, our skin, our fat, our hair, our muscle. Any skin prep solutions, 70% of them are pure alcohol, isopropyl alcohol. Our drapes and towels, our face masks, they're very, very flammable stuff. In the presence of oxygen, all of this becomes rapid incendiaries. Ignition sources, basically anything that plugs in or creates a spark when hit against something else can cause a fire. That includes harmonic scalpels, light cables, of course cauteries and laser, also high-speed drills. If your high-speed drill hits your metallic suction, it's gonna be sparks flying everywhere, so that's gonna cause fire. So this is the fire triangle. You have to have oxygen, you have to have fuel, and you have to have an ignition source. Once you have those three, fire can happen. For anesthesia, your risk management includes talking to your surgical team and partners. I don't know about other surgeons, but I love anesthesiologists. I love them talking to me. I love talking back. I may not come up with a good follow-up, but I love the dialogue because I understand what's included, what's involved. I understand the anxiety of sharing the airway, especially when you're a newcomer and they don't know what you're going to do and you don't know what to expect. After a few years together, you know exactly what Dr. Shah's going to say when I do something wrong. So you need to inform the surgeon if you're about to increase your oxygen levels, and do not go anything above what's needed. Do not use routine nasal cannula flows. You need to be more than 5 centimeters away from the cautery, from the nasal cannula. Make sure the drapes do not trap any oxygen, and use cuffed, well, this is the controversy, this is the thing. Forget what I said in the previous lecture. Use cuffed tubes. Air leaks. And if you're using uncuffed tubes, make sure that the surgeon knows about it so we can suck it out. We can suction. We can keep a suction in the field at all times. Again, keep your patient well oxygenated, but do not go maximum. Just adjust it to the patient's needs. Keep the FiO2 as low as possible, and keep supplemental oxygen under 30% when you're performing any procedures with ENT, basically. Talk to your surgeon. You can tell us, you can ask us, you can demand not to use the laser if there is any other way to doing whatever needs done. Especially to me, yes, but if you're working with one of these doctors, this one's throwing a tantrum, this one is threatening, and this one's going berserk. You know these people. They exist. They're here. Hope I'm not one of them. When laser use is necessary, use apnea, intermittent intubation, spontaneous ventilation. Use a laser-safe endotracheal tube and fill it with saline, and keep the FiO2 to a bare minimum. Here's an endotracheal tube that's laser-safe. Laser-safe doesn't mean laser-proof. It will go through if you keep the laser long enough. Laser will penetrate everything. And here's a picture of the situation with a tube, the airway, the laser working in the same place. Leak around this area is very important, and it takes just a couple of flames to scar a kid for life. If practical, we use radiofrequency ablation that doesn't really cause any sparks. You can demand that we use blunt dissection over electrocautery, and we will keep the light cords away from drapes because the temperature at the tip of this light can become under the 90 degrees Celsius. The nurses, the surgeons and the anesthesiologists working together will discuss safety concerns during the surgical timeout, and we will devise a plan. Many times the plan is very well known to us if you work with Dr. Shah and Dr. Gungor in the same room, but when we have trainees around, it's always wise and it's better practice to repeat all of those. We will keep the suction in the field. we will keep the saline on hand always a saline-filled bulb just to douse the fire. It might prevent 50% or more of the injury, just in case an open fire is encountered. We will try to avoid awake tracheotomies when possible. We will not enter the airway with the bovie or use the bovie after the airway is entered. And any suggestion to this effect is welcome. We do not mind you telling us, don't use the bovie once the airway is open. We know it, but some of us will know less than others, so just keep telling us. We will activate our tools, especially bovies, only when the tip is in view. These are surgeons' rules. We will design our draping so that no trapping under the drapes will occur. And I don't know about this, I've never done that because I don't have many hairy patients, but for adults, the health devices in 2009 has recommended that head and facial hair will be covered with water-soluble lubricating jelly. Drapes make a difference. Cellulose-based drapes ignite much faster. With a CO2 laser in room air, it ignites around 2.7 seconds. Polypropylene-based ones, even in the presence of 90% oxygen, it ignites under 1 second, but it won't ignite with fiber optic cables as in cellulose-based drapes. Skin preps, here is a combined responsibility. The surgeons will rush, the anesthesia will be doing their own stuff, and we forget that the skin prep has to be allowed to dry. If anything is soaked with skin prep, you have to throw it away and start anew. You can't be working on wet drapes soaked with skin prep because they are 70% alcohol. If you're prepping the area, just use an applicator that's proper for the area, small prep. Prevent pooling, and adhere to surgeon's preferences and routines. We are anal, we are obsessive compulsive for a reason. We want to keep variables to a minimum so we can recognize any outliers. So if you're changing anything, you have to let the surgeon know that he's prepared to challenge it or adapt to it. Have CO2 extinguisher available and conduct OR fire drills. Reporting surgical fires is voluntary, and if you do, you have to go to this website to do it. And these are fire prevention algorithms that basically summarize all of the things that I've said, and you can print these out and put it in proper places in the OR for your personnel to see, for them to be educated about. Thank you very much for listening. I'm sorry? ENTs. Yeah, I only know about the AAOHNS survey, and I think the highest rate is the head and neck. How many of them are facial plastic surgeons? I don't know. I mean, ENT includes that too, but I don't think the survey made a difference between them. Is your experience different?
Well, that's what they said in California. I mean, it was many years ago when it came out in California because, you know, they used to do outpatient surgery where they had only a nurse. She was giving anesthesia, there was no CI, there was no staff, and they're giving oxygen, high oxygen. And the plastic surgeon doing surgery and telling nurses to increase the oxygen saturation is dropping. Plastic surgeon has no experience of what happened.
There's been a couple of mistakes in the last 5 years.
Yeah.
With the Japanese opinion on plastic surgery can do
Yes.
molds or whatever and facial scars.
It all comes down to the quality of anesthesia, I think, then.
Well, they don't want to buy anesthesia.
It never is.
Thank you.
Thank you.